Okay, so we see the poor registration, high response, high neurological threshold, passive response. Sensory seeking, high neurological threshold and an active response. So I have this high need for input and I'm running around, jumping, reaching, grabbing, anything I can see, running around, going in where there's a whole bunch of people running around. Okay. Sensory sensitivity, a low threshold, and whatever's around me, I just kind of sit, not avoiding it. I just kind of sit. I don't respond to it. So sensory avoiding, a low neurological threshold, and an active behavioral response. So I have a very low threshold, and whatever you do to me, I'm actively responding. Okay. So it's real interesting. I took my grandson, who's 2.5, to see a similar to Cirque du Soleil. The first half before the intermission, he sat there, okay, and he was just watching everything. And you could just see he was fascinated. It was a high threshold and he had a passive response. He was visually watching it. We took a break and came back. And I think by the second half, what he was doing was he was sitting there pushing on the chair and jumping, watching them, doing this, doing that. And they go, well, he wants to do it. I go, no, he has a high threshold and he's now actively seeking a response. So that was one kid, same situation, different response. Okay. Now, a lot of people will think about the ecological model, and those are external dimensions, including my culture, relationships, and the tasks we choose. So in some cultures, and culture is not just different nationalities, it's anything, it's really anything, music, art, whatever. So there can be external dimensions. In some families and relationships, it is considered that we sit and eat very quietly, that when we get up in the morning, we make our bed and we do that. In other places, we're running around, eating, standing up, running around, doing more like kind of like a picnic style. Okay. So that can be, that's the culture of how we do things and our relationships with people and our chosen tasks. People often are drawn to the things that they think they like. We go, oh, well, they do it because they like it. Well, have you guys ever done something and then you go back and go, really, I wish I wouldn't have done that because I really don't like it, but they think they like it. So there'll be some type of task, cutting with scissors, coloring, okay, water play. Internal dimensions are my personal sensation, emotion, and attention. So I have to be able to regulate, and I'm looking at how I regulate my attention to the activity. You know that you've gone with someone somewhere, and when you get out, you go, what did you notice? And they've noticed something completely different than you did. My attention was on something very different than what you saw. And there's kind of an old question of this. A family goes to a parade and some of the kids sit on the little curb and watch, and the adults are standing, and they notice all the people on the floats, and they ask the kids what they liked, and they go, man, those wheels were really cool, how they were all decorated. So we see different things and what we are attending to. We attending in a very small focus, or are we looking at the whole big picture? Okay. These difficulties with modulation can either be because of our social interactions, okay, with the people situation, our environmental interactions. Is there too much stuff in the area I'm trying to do my homework? Okay. And self-regulation. Okay. And we often think we don't really look at that there's too much going on when people are trying to read or concentrate. Okay. So sensory modulation disorder. Now we look at those same types of personalities. Someone has defined the sensory over responsivity. Whatever happens, they're overreacting, wildly reacting. It can be making noise. They can be jumping. They can be grabbing. Okay. They can cover their ears. There's sensory under responsivity. You're bombarding me with things. Doesn't make an effect. And then there's people who are sensory craving. Okay. I constantly want to be doing this, constantly want to be looking for something else. That's different than over responsivity. But there's a whole bunch of different things, different approaches there. Now, if we look at our sensory-based motor disorder, now notice if we call it a motor disorder, sensory-based, It is going to be based on challenges in proprioceptive and the vestibular system. They're going to be difficulty planning movements, especially new movements or complex movements. These are the kids that look kind of clumsy when they're trying to play a ball, kick a ball, play soccer. Okay. They may also have decreased muscle tone that can affect their stability. Okay. So it's not just the sensory part, it is the postural part too. Okay. So here are some sensory processing. Here are some presenting signs and symptoms. Extreme responsiveness while engaging in activities. Stress, frustration, trying to start to cut, and then they get mad because they can't do it. Okay. Because it's too much. And we see this in ourselves. You're at the end of the week. If you have kids, they're running around, you've got all this stuff to do and everything else. And what happens? You get mad because you can't get something out of the washer. You get mad because of something else. This is what kids do. Okay. We underestimate the role of low responsivity. We don't tend to notice these kids because they're kind of sitting around and they're not making noise and they're not disrupting our lives. Oftentimes there's difficulty interacting with the environment, learning, and social situations. Now, think about that as a component of what we talk about when we talk about autism with engaging with people socially in communication, but we'll get on to that. Difficulty motor planning. Any type of aspect of figuring out what I want to do motor-wise, planning it, doing the sequencing, or executing it. That's called dyspraxia. And you will see kids that will start to cut something, then they want to glue it, but they haven't finished cutting it out. Okay. And then they want to glue it, and then they want to go back to cut it, and they can't do it because they haven't sequenced all the components. Okay. People that have trouble with these things tend to reject or avoid them. You and I do the same thing. I do the things I'm very good at. I'm good at social dance. I do that. Okay. I tried pickleball. I think I'm good. No one else on the court does. Okay. So I tend not to do that activity. I love it, but I get a lot more satisfaction of doing something that I feel good. We all do this. Okay. Okay. We have poor initiation of the activities. They can't really figure out what they want to do, poor ideation. And we often confuse, oh, well, they really can't cut with a scissor. Oh, they really can't do this activity. They can't play the game. It may be that they have difficulty generating the idea or the basic concept and initiation. Okay. So all these responses are on a continuum, and they are extremely individual. There are going to be no two people that are very similar or alike. Okay. And even you and I notice over time, we change our responsivity. Okay. So when we think of tactile defensiveness, there's over responsivity to ordinary touch, anything from a variety of textures. And there are some people, you'll see it, they can't stand to touch grass. They can't stand to touch glue. There's kids that if they're learning how to eat and they have to wipe their face, they can't stand this. Okay. Kids really hate having their hair or teeth brushed. Okay. And so they may get angry and upset, and parents go, they're having a tantrum. No, it's often sensory. Now here we talk about the under responsivity, and I'm going to go to the next page because that's how it works here. Okay. Okay. Then we have the under responsivity. We have the tactile processing dysfunction. So difficulty in regulating and organizing it. Okay. I'm sorry, we did this under responsivity. They don't respond to normal levels of tactile input. Hey, let's go. Time to eat. Time to eat. Let's go. They really do not respond even to those simple commands. Okay. And they need to have a whole bunch more stimuli, okay? Which drives us a little bit, makes us confused. Should I say it more or should I say it less? Should I give them time to respond, or should I reach out and say more? Deficits in tactile discrimination contribute to impaired body scheme and somatodyspraxia. This has to do with, remember, somatodyspraxia. Somato means body, and dyspraxia is movement and motor planning. Remember, apraxia, dyspraxia. So when we have this somatodyspraxia, it means there's a tactile component that affects their ability to do motor planning. Okay. And one of the things that would be considered that, if I can't figure out where the jacket is on my hand, it may be really hard for me to get it on. And if I don't perceive that, or if it's too touchy for me, I may not want it, or if I can't perceive it, I can't get dressed. So that's kind of a motor planning. People are awkward. It contributes to problems with visual perception, eye-hand coordination. Okay, and then we're going to go back to the other page because that's how this rolls. They have difficulty locating tactile stimuli. My favorite sensation in the whole world is stereognosis. I absolutely love stereognosis when I am, okay, I don't really do this, but when I'm trying to find something in my backpack when I'm sitting at a red light. I know I can't take my eyes off the road, but I've got to find it, and I feel it and I go, nope, that's not a pen. That's just my lipstick. Nope, that's not the pen either. Okay, nope, that's my cord. Okay, and finally I find my pen. Okay, if they have poor tactile stimuli, they're going to have poor stereognosis, and they're going to need to use their eyes to see to do things. Okay, which is going to affect their eye-hand coordination because they're looking over here to see what they need to grab, but they're really working over here with something else. Cutting with scissors is a problem. So then we have proprioceptive processing. This is challenges with awareness of the position of body and the body scheme. Okay. Now that sounds an awful lot like that vestibular sensation, but this is position in space. They are often very distractible. Why are they distractible? Because they are spending so much time figuring out how to reach up and grab this cup. Okay. That they kind of forget, and they're distracted. They kind of forget what they were doing because they need to focus on this instead of just grabbing the cup while they're painting. Okay, so motor planning problems, vestibular processing, hypersensitivity to movement. They don't want to be doing anything. They don't want to be doing anything on their own to move. They may not want to walk sideways. They don't want to run fast. Okay, they don't want to do anything where they have to move a whole lot. They're very sensitive to the movement of themselves. Okay, hyposensitivity to movement. They often seek intense vestibular stimulation. They don't feel dizzy, and people call them a thrill seeker. And you see these kids that spin around, they run around, they jump on the ball. I had 2 grandkids this weekend. They were jumping from the sofa onto a mattress on the ground. I was just thinking something's going to happen. They just kept doing it more and more and more. They were just seeking this sensory input, and then they were screaming too. So not only did they have the auditory thing going on, they had this vestibular movement, and then we got the tactile input and where their body was in space. So we got the whole 9 yards. Gravitational insecurity is excessive fear during typical activities, and this has more to do with specifically when they're moving forward or backward, walking on uneven terrain, okay, jumping, okay, and it has to do with, that's where we really notice it, playground equipment and getting on and off of a ball and getting on and off elevators or escalators. They have a real challenge with looking where the ground changes. Okay, so that's gravitational insecurity. I have a little trouble distinguishing hypersensitivity to movement from gravitational insecurity, but hypersensitivity is more like a sympathetic reaction. Gravitational insecurity is, I just don't want to do it. I don't like it. Okay. So vestibular processing, hypersensitivity to movement. Now we just talked about the gravitational insecurity, and now we're talking about vestibular processing. This can be, sorry, I just said that. Okay. Vestibular discrimination deficits are characterized usually with low muscle tone. So when we think vestibular discrimination, it's not really the high muscle tone, low muscle tone, and very difficult, we call postural ocular movements. And we'll notice this if kids are jumping and that we try to get them to focus on something and they look around, or they're jumping and they lose their place jumping because they can't focus. Okay. Decreased balance, poor equilibrium reactions, and a low endurance, and difficulty in motor planning and sequencing. Now notice we see some of those in some of the other conditions, but this has to do specifically with movement. Okay, that is sensory processing in a nutshell. A lot of stuff going on there, and let's see how that kind of parlays into autism spectrum. I am using the older version books. Okay, the newer versions have a little bit less of some information, more of other information. Okay, chapter 10. I'm not going to go over the numbers, the ages, where it comes from, how it's common between boys and girls. They're not going to ask you that. We know it's an organic brain pathology. I don't think they're going to ask you that either. Okay. Okay. The prognosis for children with autism is dependent on the severity, the general in intelligence, and the change in symptom expression over time. Okay. We know that they follow the same continuum for intelligence as the typical population, from very, very low intelligence to very high and gifted intelligence. Okay, we know that. So when we say change in symptom expression over time, some kids learn how to work with what they have. I have a little friend that I play with and see. She's 6.5. And I was playing with her with a bunch of kids. And she said, I don't want to go in that room. And I said, why not? And she goes, too much. And I said, too much what? And she couldn't quite put it into words, which I don't expect kids to, but she said, it's too much people. And I said, do you like the noise? She goes, no, it's too much noise. And then later on, we went to another place and I said, what about this? And she goes, there's not too many people. So what about the noise? She goes, there's not too much noise. So she was starting to learn that. And now she's aware of herself of what, and so she's going to do better in understanding what she needs to avoid and what she needs to do. So diagnostic characteristics have two core symptoms. One of those is impaired social communication, and the other is, hope I can see it over here. Okay. So that has to do with nonverbal behaviors, difficulty relating to others, lack of spontaneous social behaviors, and lack of understanding. It's difficulty with the initiation. Okay. And it's not being able to read those subtle symptoms. A lot of times you'll see people will not make eye contact. They may repeat what someone says, and they may have echolalia with speech. Do you have a dog? Do you have a dog? Do you have a dog? Yes, I told you I have a dog. Yes, do you have a dog? Yeah, I do have a dog. Do you have a dog? Yes, I do. Or we talk about the hand flapping, so it could be that. Okay. So let's go here a minute. So all these different types of communication, delay in social interaction, okay, and difficulty with sensory processing. Notice that the DSM-5, not that we're tested on that, looks at communication, looks at repetitive behaviors, stereotypical behaviors, and they will look at poor ability to relate to other people. Those are diagnostic characteristics for autism. Sensory challenges are not, according to the DSM-5, diagnostic characteristics of autism, but that's what we work with a lot. Okay, so just because it's not their diagnosis, it's what we see with kids, and this is what we do. Okay, so we see these changes in communication, repetitive stereotypical behavior, delay in social interaction, and there may be, we talk about difficulty with sensory processing and perception. It can be hyperresponsivity, hyporesponsivity. We really think of this hyperresponsivity where kids hold their ears, close their eyes, go like this, okay? But there is hyporesponsivity. Now, we also often think of unanticipated mood swings, temper tantrums, lack of ability to focus, insomnia, and enuresis. Okay, I don't want us to say they had a temper tantrum because they had autism. They may have had a temper tantrum because they really wanted candy and they couldn't get candy. Okay, it may have been a really typical child behavior to have the temper tantrum. So we need to distinguish when those are typical and when they're related to the autism. Okay, so we're gonna over here now. Oh, okay. Okay, so we're going to talk about that we may be doing augmentative communication for some kids. We may be doing positioning equipment. Okay, some people will require something to help maintain the integrity of their skin. If kids with Rett syndrome, that is now called known genetic condition, may be doing this, we may have to do something to keep their hands from their mouth. Okay. And we want to look a lot at the family and the team to promote this, because you can't just do one treatment on somebody and leave. It's not like I'm going to go do some range of motion and that's it. Okay, so I'm going to talk a little bit about sensory processing assessments. Chapter 5 has 2 sensory profiles. They identify for 4 categories. And I love how they say these words instead of minimal, moderate. They're typical, they have no challenges. They probably have a sensory challenge. They definitely have one, or they have a significant one. They're questionnaires, which means they're going to be subjective. Okay, it's very hard to quantify a lot of the behaviors that we see. So we're going to have people observe and judge their responses, their processing, and their modulation to sensory exposure, to tactile input on the face, on the arms, on the legs, the wind blowing on their body, something like that. Okay, auditory, gustatory, smells. Okay, so all the different sensory processes. So this is definitely subjective, and this is used to get information to be able to develop an intervention program and for them to develop their sensory diet. Now, notice we have a sensory profile for infant and toddler. Obviously, questionnaire for these kids up to 36 months by the caregiver. Okay. Then we jump to age 11 to 65. Okay, we have an adult adolescent where people themselves identify personal behavioral responses to daily sensory experiences, the things I typically do during the day and the typical things I avoid, the things I'd like to do during the day. Now, some people can do this independently. Other people, it may be in the more form of a questionnaire. Now, what do we have in the middle? We have nothing from 36 months to 11 years. We do have the childhood rating scale, the CARS, over age 2. This has a very good way of looking at children with autism versus children with developmental delays without autism. And they do range in on a level of mild, moderate, or severe autism, or no autism, just developmental delays. So they will look at 15 statements of their abilities, their behaviors, characteristics, and they give scores for these. There's a scoring thing there. Okay. And the sensory process measure, elementary school kids. The beauty of this is it addresses sensory processing in all areas, praxis, so motor planning, motor skills, social participation, and it looks at it in different environments, not just when it's school. Some kids do really good watching TV. Other kids do really good when they're riding their bike. Other kids do really good here. Some kids do great in school and break down when it comes time to do a sport. So we want to get different environments. Notice we're looking at visual, auditory, tactile, olfactory, gustatory, proprioceptive, and vestibular behaviors. There are three people getting their eyes on this. One is the caregiver at home. They're going to have their perspective in their environment with their siblings, their family, and their everyday activities. Another one will be the primary classroom teacher giving information. And then we have a school environments form. This can be the OT, the speech pathologist, maybe a paraprofessional. Maybe they have a paraprofessional person helping them, a counselor, or someone who has a lot of contact with the person to offer. Based on that, we can get a bigger picture of what's going on. So those are our sensory processing assessments. Can be used on kids with sensory processing challenges or on the autism spectrum. Okay. Sensory integration and praxis test. Good news is you have to have 2 years of pediatric experience, and you have to be certified in this. I'm certified in this. It is an arduous process, and it's very, very tough. They should not be asking you anything on the sensory integration and praxis test, except to know that it is Jane Eyre's theory. Okay, the DeGangi-Berg test of sensory integration can be administered, and I'm sorry I don't have the ages here, but that is a test of their sensory processing, and it can be administered by an entry-level assistant or therapist. And we know that assistants will administer the non-interpretive aspects, okay, if they have the service competence, and the OTRs will interpret those results. Okay. big thing. This is either going to be table 10.4 or 10.5, whatever book you have. This is kind of the bottom line. They should be asking you, we just had a question about what kind of activity should we do for a person who has this problem or this particular challenge. So this is really the bottom line. What do I need to do if somebody is not engaging, they're not interacting, they seem fearful, or they're anxious? Okay, look at this. Imitate the child. And I think it's very important to imitate them to show you're coming into their world. And I'm going to give you a great example. I did a volunteer project in Jamaica in an adult group home, and we spent the day at one of the homes with the children, And there was a girl who was probably 5'8". She was 18. Not engaging with anyone. They would try to dress her. She would run around naked all day. She just ran and ran and ran, and they could not relate to her. They tried to get her to do stuff. And I said, try this. I'd never seen her before. She was sitting down, and I went over and sat about 2 feet from her. And I just sat there. I didn't look at her. I did exactly what she was doing. She had her 2 hands on her lap. She was looking straight ahead. Okay. And after a while, she kind of looked at me, and I just kind of glanced at her, and I really imitated what she did. And then I put my hand and I said, like, come closer. She moved closer to me. Okay. And we sat there, and eventually she put her hand on my hand. They said she hadn't done that with anyone. I said, all I did was sit there. You don't want to work real hard? Sit down with her and just sit. So imitate the child. And I suggested they continue to do this. And we talked about how they could get her dressed doing this. It's going to take a while, but you just have to be patient and take some time. Okay. And then reduce eye contact and alter. We must meet them where they are. We must meet our voice volume. We have to really remember what we're saying to people. And that's why those funny songs are fun. And things like that make sense, that make fun and have fun, because it's not somebody saying, do this, do that. So there's some more ideas in there to really look at these. Think about motor skills and praxis. Here now we're talking about obstacles, challenges that get people engaged. Here, let's pick up these bean bags and throw them in the basket. Oh, you're too good. Oh, whoops, I dropped my bean bag there under the table. And get them to go down and make it harder and harder and engage them. But we have to start off with doing something they do well. Notice I went from here to doing something when we're talking about motor skills and praxis. I did an activity, something active. With the other person, with the fear and anxiety, I just sat quietly. Okay. And then I would also have fun and do silly things with them. Okay. So motor skills. Okay. I would encourage the use of the simple motor skills. Row, row, row your boat. Okay. And then this is a great example. Row, row, row your boat. Instead, sing push, push, push that cart gently down the hall. Okay. Do things like this. Everything involving motor skills. Okay. And progressively grading. Okay. Reducing comfort, reduce fear and anxiety. We've got to engrade the introduction of novelty. A lot of our kids don't like new things. Don't like change. And I know some of you are going, I don't like change either. I like change when I get to do it. I don't like change when you tell me what to do. Okay. So you want to make sure how you're going to increase novelty to decrease the anxiety. Okay. And be very aware of our smells, our noise, our lighting, and any kind of triggers. And this is a real good way to get deep pressure and proprioception. If they will grab your hand, push against your hand, okay? Maybe sit in the chair, do a little bit of rocking where they can do their own proprioception, maybe get on hands and knees and push down through their hands, okay? Improving behavior task completion, okay? Help the kid figure out what they're supposed to do next. And this is great in reading a book. What's going to happen next? How many times is it going to happen? Okay. And do things that are familiar to the child. Choice is a huge thing. I like to start off with choice of 2 things. I started with my grandkids, 6 months old, held up 2 books. My kids go, how do you know which one they want? I said, they're going to tell me. And they would keep looking at one book. That's the one we would read. We start off with choices and then play and ideation apraxia, you want to do realistic prompts. Realistic prompts. It's great to have, that's why these little kids, okay, they do fireman's hat, realistic dress up clothing. We cleaned out a closet this weekend of grandkids. Paw Patrol, Elsa. I can't even tell you all the different ones they had. And we just spent so much time putting them on and talking about what they were going to do and how Elsa got along with Marshall from Paw Patrol. And then the fireman came in, okay, and to promote this imagination. Okay, so I'm gonna let you go over all of those. Okay, and that's basically sensory processing, autism, and really be aware of these specific strategies. And I think it's really good to think in 3 dimensions. If you have somebody that has a challenge with their behavior, see them doing this, sit there and do it. If they're putting on a fire hat, sit there in the exam and do it 3-dimensionally. Okay, so I'm going to turn off the recording, I think. If I can figure out how to do that, turn off recording. I'm going to quit. Turn off recording. No, that's my screen share. You're still seeing the screen, right? Oh, well, I have a question here. What is considering a passing score? I have enuresis is bedwetting. Okay. We usually say people who do about 65 or so do well, but there's other factors. That is a scrimmage game. Okay. And then you go to the Super Bowl. You go to the Super Bowl, you bring it up to the next level, you do great. If you get kind of nervous, you know, they have a lot of nerves and other things that come into that. So that's typically what people do. But those 3 tests are really designed, those 3 practice tests or scrimmages. It's not designed for you to go, oh, I only got a 62. It's designed for you to say, what did I do well? What do I need to work on? Do that. Patrick Mahomes did not go out in a scrimmage game and shoot 100%. He went out and he said, I tried this, it didn't work. I tried this, it worked. I want to keep working on this. That's all they are. So I'm going to take a little bit more real quick before we go into your questions. These are some topics for office hours that we have. Okay, I don't know what's coming up next week. I know I switched. I was not supposed to be this week, but we switched. This is great. I come and listen to these because I still learn a lot of things. The groups, the neurocognitive disorder, risk management, safety, fine motor skills, mindfulness, diabetes, renal disease. Okay. In a minute, I'm going to say any questions you want about preparing for the exam, test taking strategies, the certification exam, anything that I know about NBCOT, I can tell you. I just want to tell you that we do have a course and a book. I highly recommend the course because I've taught almost 400 of them. And I think it's been very helpful to help people organize, break down questions. When you go to that course, you will get a course manual and those are the course manuals for the OT and the OTA. They're older versions and newer versions. Okay. You can do you get access for 12 months and you can take them one time. You should take them one time, 4 hours at a time, but you can go back over the questions all the time. Okay, and then you'll get an answer with specific rationales. We also have the mobile test prep app. It was originally a lot of questions we had already on our practice tests. We are pulling those out as we get new questions. You know, it does take a while to make really good questions in the mobile app, and it gives you, with AI, it gives you immediate feedback and tells you what you need to look at and study. Want to tell you that, you know, our office hours are free. It's an hour long. 7 p.m. Eastern, 6 p.m. Central, and it's at the same time, and they will be up, and you can go look at 4 weeks of lessons right on our website. We also do tutoring. I've been doing tutoring for a long time. You can do it one-on-one, or you can have 2 or 3 of you in one session, 60 minutes. We will give you an individualized session there. Every single session is different. What I tend to work on is helping people get organized, going over content they're challenged by, and stress management, and getting a different focus to get in and take that test. We have little strategies for that make a big difference. And what I do a lot is go over our practice questions, break them down, because you have to understand how to answer questions. I've worked with people who are taking it, haven't taken it yet, and I've worked with people who've taken it many, many times. Okay. So we do that. And oh, where I got lost here. Okay. Okay, so I'm going to ask if anybody has any questions, open it up. And I gotta quit the record. I'm gonna stop share here. I gotta figure out how to stop the recording. Okay, got it.